what they found was the change in nanomoles was only about 72 nanomoles of hydrogen ions, and the pH dropped from 7.4 to 7.14. But actually, how much of this one they had given was somewhere in thousands, so 13,000 odd, 13 million odd nanomoles were infused, but there was only a change in this one of 36 nanomoles. How does this happen? This gets hidden by a buffer system. What are these buffer systems? Now, when you look at the buffer systems, the major buffer system that we actually look at the buffer system as far as interstitial fluid is concerned. Then your extracellular fluid. In the extracellular fluid, again, you have your intracellular fluid. Extracellular fluid, you have your blood, your interstitial space, and then of course your other the lung, and then the kidney that also takes part as in your acid base physiology. Now, of this, fortunately, all this buffer system, they are they all sync and then they work together. So if you look at one buffer system, we are able to assess if all your buffer systems are reasonably working. So what we try to do is we try to look at the bicarbonate change, and by this bicarbonate change, we actually try to interpret what is happening to the patient's internal milieu with the acid base that's in the blood. So when we look at a ABG, let me go through now let's go to the actual interpretation. Now, when you look at a ABG report, you have certain parameters called as the measured parameters. Then you got your corrected one. I'll just go one by one. Now, the measured values are measured values, then the corrected one. Is there any value to it? I'll just come to it in the subsequent slides. Then comes the calculated data. See, these are all not measured, but these are calculated by the machine. And how does this measure? Because they would have fed a nomogram into the machine, and for this pH, for this PCO2, what should be the bicarbonate? That is how the machine actually gives you the value. And this has been fed by the company itself, based on, like, if it's your standard basis, it's from your Sigurd Anderson table. Similarly, if it's your the bicarbonate, it's from your. I'll just come to this on the subsequent slides. And subsequently, you have a calculated one, like which I told you, and then the entered one. Entered one are the one that we actually enter into the computer, into the machine. So the temperature of the patient will be entered by us. Some of the machines do come with hematocrit, but otherwise we'll have to enter the hemoglobin and then your FiO2. If you don't enter, probably what will happen is the calculated data that you get might come as a question mark, or it will be in dots. So let us go one by one now. Now, what are the measured values that actually the machine measures? One is the pH, second one is the PCO2, and third one is your PO2. And this, as anesthesiologists, we all know how these electrodes these electrodes are the one which actually measure your pH. Your Savernier's electrode measures your PCO2, and PO2 is your Clark's electrode. Now, additional parameters, newer machines actually come with coaximeter as well. So your saturation SaO2, small AO2, that is given by some of the machines will be your coaximetry values, and it will be the measured one. But most of the time, it might be your derived one from the nomogram the machine would have been fed with. So that is something what you should remember whenever you look at your SaO2. Similarly, newer machines come with your sodium, potassium, calcium, chloride, also hematocrit and lactate. Now, I'll just come to all these things in the subsequent slides. So most of the newer machines come with your pH, PCO2, and PO2. And apart from this, they also give you sodium, potassium, calcium, chloride. Some of them might not give you might not have the potassium. Some of them might not have hematocrit. And most of the machines nowadays come with your lactate also. Now, regarding temperature correction, right now, as far as in the day-to-day practice, what they say is you don't have to really look at this values, temperature correction, unless you're working in a cardiac unit where you cool the patients to very low temperatures. Otherwise, this corrected value does not have much value to it. So let us take it off the report. Now, next one, how does this machine actually calculate the bicarbonate? The bicarbonate, mind you, is not measured one, it is calculated one from the ABG. Whereas if you send electrolytes and you get the you get your electrolyte, your bicarbonate in the venous sample. That is actually the measured one, but it is not the bicarbonate that's measured, but it is not the bicarbonate that the machine measures, but it is your TCO2, your dissolved carbon dioxide in the plasma, that is measured by the machine. So generally they all go hand in hand. Means the venous bicarbonate will be, if you do a venous blood gas also, the numbers will actually most of the time will correlate. There won't be a much problem. This one discrepancy as well as measured or calculated. Now, how does it calculate? It calculates from your Anderson-Hasselbalch equation, and you have your pH, you have your PCO2. Sorry, I don't have a pointer here. Anyway, you have your, yeah, it's here. Now you have your PCO2 measured, you have your pH, and by this you measures it calculates your bicarbonate. That is how the machine actually calculates the actual bicarbonate. Now let us go to the next one. Now, what are the standard and basics? Is this I'll try to, I'll not stick to, I'll not, because this is more used in your basics based deficit. When they use this method, when they use the Copenhagen method, that is where this basics or the standard bicarbonate comes in. I will just try to skip, but let me see what it is. Now, what it actually reflects is, it reflects the non-respiratory acid-base change. It does not quantify the extent of the buffer-base abnormality, and does not consider actual buffering capacity of blood. And usually what it does is, they give the it calculates the bicarbonate. If the patient's the PCO2 is 40 here, it takes it brings the PCO2 to 40, and then 44 here, it brings down the PCO2 to 40, and then it tells what would be the bicarbonate with PCO2 of 40. That is how it actually gets your standard bicarbonate. I'll not go to this because I'm just sticking to Boston's method. So base excess again, this is, and how do they actually, this is again a calculated one. They would have fed a nomogram into the machine, and this gives your basic base deficit. What they say is, your basic base deficit is misinterpreted in chronic or mixed disorders. Whereas, if you look at the Copenhagen people, they'll always say that the Boston method is the one which misinterprets your chronic mixed disorders. But in day-to-day practice, what we all come across is, most of the time it'll be either the majority of the time it'll be one single disorder, or it might be a double disorder, or very rarely you might have triple disorders also. But for us, main thing is, we should know when the patient is acidotic or alkalotic. That is enough for us to, and this Boston method is enough. So I'll not go with this standard bicarbonate and base excess. Then it's your calculated parameters. It gives you the oxygen content. It gives you saturation. How does it? So like I told, if a machine has got a coaximeter, it will measure your saturation. Otherwise, it will just derive the oxygen saturation from an ideal OD curve. So the patient's OD curve might be shifted to the right, and so it might not correlate with the patient's with your patient's SaO2 might not be at the actual SaO, the measure, the machine, the report is there on the machine, on the report by the machine might not be the actual SaO2 of the patient. So that is something what you should remember. So this more so, a lot of patients believe in this mixed venous oxygen saturation, or the venous oxygen, central venous oxygen saturation. So it might not be the actual patient's mixed venous oxygen saturation if it is a saturation that is derived from your OD curve. If it's a coaximeter, well, that will correlate. But otherwise, you should be careful with this one. Now, next is your AA difference. We all know this is the ideal ILR equation. So first is your PiO2. So PiO2 with the 21% of oxygen. This is your, so small iO2 is your partial pressure of inspired oxygen concentration. Now, not concentration, partial pressures. So now this will usually be 150. Now this is your ideal ILR equation, and then from this you calculate your AA difference. Why is it important to know whether the patient has got hypoxemic failure or it is a ventilation failure? This will help you in when you get this AA difference. Normal, this one is about 10 millimeters of mercury. If it is increased, then you know it is hypoxemic failure. I'll come to this one. See, normally the difference is about 10 millimeters of mercury, and it will vary with age. As the age increases, the age difference increases. When it is not correlating with the age, and then the age difference is more, it tells me that patient has got hypoxemic failure, oxygenation failure. And if the age difference is normal, it tells me that patient will have. So it will be see, like I've just done a this one here. Now when a patient has got oxygenation failure, you calculate your AA difference. Now AA difference is nothing but your you from your ideal Euler equation, you get your P capital A, that is your alveolar partial pressure, and then your PaO2 is your what is the machine that has measured you and given it to you. Now the patient's PO2 is either 40, 45, but the A difference comes to about 55 in this patient. So for this patient, there is a difference is more. So this patient has got oxygenation failure, whereas a patient who has got ventilation failure, what happens is the PCO2 goes up, and then your difference, your PO2 will be 45 here again. But if you look at the AA difference, it'll be only 5. So that is normal. So by this, I can actually say whether this patient has got oxygenation failure or I got ventilation failure. But most of the time, it will be a combination of both. Very rarely we do find a patient who's got it might not be a combination. If a patient has got pneumonia, has got pathological shunts, what happens is obviously the AA difference will be high, so a patient has got purely oxygenation failure. Whereas a patient with COPD comes with wheeze, and then he comes drowsy. I check his PCO2. PCO2 is 80. This patient will have some amount of hypoxemia as well. So he'll have both oxygenation failure and ventilation failure. It might not be one problem all the time. But when you look at the AA difference, you know this patient got whether this patient has got pathological shunt, whether this patient has got ventilation perfusion mismatch, or it is more of ventilation failure. Now, some of the machines do give you the A ratio also, proposed to be less reliable, but limitations are the same. It goes, as the age increases, the A difference actually goes up. Now, so after I've gone through the report, let me see. I'll just tell what are the parameters that we look at, because I told you the temperature correction I don't I don't look at it. Second is here, and then I don't look at the standard bicarbonate. I don't look at the base excess, but it is not. I don't look at it. It doesn't mean that it should not be there in the report. It should be there, but for the day-to-day practice, as far as Boston method is concerned, we don't need those parameters to be taken into consideration. So most of us will get confused because we take both the parameters. Some of us use Boston's rules, and then we also look at the base deficit. We don't have to do like that. Just stick to one rule and then try to analyze the ABG. Now, when you look at a blood gas report, you have your pH. The normal pH will be 7.40 plus or minus 0.05. PCO2 would be 40 plus or minus 5. PO2 is 80 to 100 millimeters of mercury. Up to 60 is acceptable. Less than 60, we always say patient less than 80 is hypoxemia. But when somebody's PaO2 is less than 60, it is always bad. So we need to make sure the patient's PaO2 is at least 60. Next is your bicarbonate. Bicarbonate, it is 24 plus or minus 4, and the oxygen saturation, it should be more than 90. And then your AA difference, like I told you, is 10 millimeters of mercury. And if you know the age of the patient, you can actually, as the patient's age increases, the AA difference will also increase. So the other the formula which is easier is age divided by 4 plus 4. That is your other formula that you can use for this calculating the AA difference. Now let us go one by one. Now, before going on to the ABG itself, what are the technical errors we should keep in mind regarding glass syringe versus plastic syringe? Nowadays, we don't get glass syringes at all. Probably, I don't know in government hospitals, but at least in private hospitals, we no longer have glass syringe. Not that it is not good, but previously we used to say that if you use glass syringes, the change in PO2 or PCO2 does not actually happen. Whereas nowadays, what they say is whether it's plastic syringe or glass syringe, the changes are not that clinically important. Second is the heparin. Heparin, you should always use heparin in the concentration of 1000 units per ml and not. So blue vial should be used whenever you are taking blood sample, ABG samples, because the pH of heparin is 7, so it is acidic. And when we use more heparin in the sample, the PCO2 tries to trend down. Second is it can become, it can have the sample can become more acidotic. And then the third one is your heparin is negatively charged, so it can bind to your sodium, potassium, calcium, magnesium ions, and so erroneously your values might be low. More so with calcium. That is why never rely on your calcium values, ionized calcium values that is given on your ABG machines, because it can bind to heparin more often as compared to sodium, potassium, or magnesium. And sodium, it doesn't really matter because it's in hundreds, whereas potassium, calcium, magnesium, it's in only single digits. So that is something what you should remember. So don't go by your potassium, calcium, magnesium values in ABGs because of this problem. And then how to overcome this one? Always take as less as heparin as possible. So you take heparin, aspirate, and then flush it completely. Or if you have a pre-heparinized syringes like lithium heparin, uh, newer syringes come with this one. But there's a problem again in this pre-heparin. One is it is costly. Second one is you should actually draw the whole syringe. Means if the syringe has got a capacity of 1.5 ml or 2 ml, the whole syringe has to be aspirated. If the sample is less, you can have more heparin bound to the syringe, so you can get a less pH. So that is something we should remember about heparin. And then delay in measurement, it can be easily circumvented by using ice slush. Ice slush means it has to be crushed ice. It has to be at 4 degrees Celsius, crushed ice. And if you put the syringe inside, and then you can store it even up to 1 hour without any major drifts. But it's a challenge even in the most of the even in my hospital. It takes at least 30 minutes for me to get a blood gas if I send it to the lab. If I have a stat lab, I'll get it immediately. But most of the time, it will take at least 20 to 30 minutes. By the time the sample goes to the lab, they run it and then give the report, it will be at least 30 minutes. So it's always better, it's always wise to keep ice slush in your ICU or in your OT, and then put the syringe in it and then transfer it. Now, let us go to the steps of ABG analysis. There are 8 steps totally, and not all the time you need to go through all the 8 steps, but it has to be more systematic. So, like I told, we look at one is your acid-base status, and the last is your oxidation and ventilation problem. So, first we look at the acid-base status. What are the patient's acid-base status? So, I'll use your Boston rules, and then Boston rules, most of them criticize, telling it involves a lot of mental gymnastics, but they're only for 4 formulas that we not four. It is about 6 formulas. If you memorize or you carry with you and then keep doing it, you get a hang on it. So it is not that difficult, but you need to apply the rules all the time. So that is something that is important in ABG analysis. Even if you go for base excess, base deficit, again there are so many equations there also. We have Van-Slyke's equation, and then there are equations to know whether to check whether this patient's base excess is normal, abnormal. So even that carries a lot of formulas. And Stewart's approach is much more complex, because you need to get all the ions also apart from your sodium, potassium. You should know your albumin, you should know your lactate, you should know your phosphate. So Stewart's approach is something that is more physiological, more scientific. But in fact, in European ICUs, most of the anesthesiologists and intensivists, they use Stewart's approach, because they have all the parameters with them. Most of the time, most of the blood, they get all the phosphate. But whereas in our setup, we don't regularly measure phosphate, we don't regularly measure lactate. Of course, now the newer machines come with the lactate, but previously, about even 5 years back, we didn't have machines that used to give lactate along with the other parameters. So let us go one by one. Now, as I told, first is acid base status, second is the last is your oxidation ventilation parameters. Now let us go. Now the step one is Now look at the pH. I'll just do few ABGs at the end so that we'll get more acquainted to this steps. First, look at the pH. The first thing is what we do is look at the pH. So whether the patient's pH is, if the patient's pH is less than 7.35, patient has got acidosis or acidemia. Acidemia is it's a nomenclature that, because acidemia is a clinical state, whereas acidosis is a biochemical, or it is more the cellular level. Acidosis is the cellular level. The acidemia, it is like anemia and anoxia and hypoxemia. Similarly to that, hypoxia and hypoxemia. Similar to that, you should always call it acidemia, alkalemia. So that is how the actual terminal that is used, but we tend to interchange it. So acidemia, if your pH is less than 7.35, it is acidemia. Alkalemia is pH is 7.45, more than 7.45. Now, step 2. So after step 1, we need to see whether the patient has got metabolic or respiratory disturbance. Now, if it's acidosis, if your bicarbonate is less than 20, then it is metabolic. If the PCO2 is more than 45, then it is respiratory. Alkalosis, bicarbonate is more than 28, it is metabolic. If your PCO2 is less than 35, it is respiratory. So step 2, we need to see what is the direction in which your bicarbonate has gone or your PCO2 has gone. So that tells you whether it is respiratory or metabolic. Now, next, after this, if it's a step 3 is for respiratory problem. Step 3 is for respiratory problem. It's not for metabolic problem. What is step 3? Now, step 3 is, so like I told, let us go through. So just to recapitulate, acidosis, in respiratory acidosis, bicarbonate will rise, pH will come down, bicarbonate will rise. And we call it as acute respiratory acidosis. If the if it is less than 24 hours, it is acute. If more than 24 hours, it is chronic. Alkalosis, bicarbonate will fall. In respiratory alkalosis, bicarbonate will fall. So the change will be in the opposite direction. Your PCO2 goes up, bicarbonate will, sorry, it will be the same direction. So the pH will go down, PCO2 will go up, bicarbonate will go up. In alkalosis, it's the opposite. PCO2 comes down, your pH in the bicarbonate also comes down. So in alkalosis, we always say talk in terms of hours here, because respiratory alkalosis is one metabolic disorder which will get completely compensated, and within 24 hours, within 2 hours, you will see it becomes chronic. The reason is that your compensation is so excellent, because your lung is able to wash out your carbon dioxide so well that this one tries to your pH tries to come back to normal within no time. Now step 3 is, if it's a respiratory disorder. So again, step 1 is looking at the pH. Then step 2 is see whether it is respiratory or metabolic, which is predominant. Step 3 is, if it's a respiratory disorder, what is the expected delta? Delta pH is nothing but your change in pH. Now, before going on to this step, I would like to tell you, in Boston rule, there are few things what we should remember. One is, you take your pH, normal pH is 7.40. For all calculations, your pH is 7.40 is normal. Similarly, your PCO2 is 40. And then your bicarbonate is always 24. So these are your single numbers. So this is something what this is the number what we use for calculation. So what is the expected pH if it's acute? Acute means it is less than 24 hours. So in acute, it is 0.08 into delta PCO2. Suppose your your PCO2 is 50. That means the change in PCO2 is 50 minus 40. So that is 10. So 10 divided by 10. So it will be 0.08 into 10. 10 by 10 is 1. So 0.08 into 1 will be 7.40 minus 0.08. So that will be my that will be my change in pH. So that will be my expected pH. Similarly, for my expected delta pH in chronic, it will be 0.03 into delta PCO2 divided by 10. When I do the few of the ABGs, we'll be able to, you'll get a hang on it. Now, going on to the next step. So step 3 and step 4 is for respiratory problems, not for metabolic problems. Now, step 4 is, you look at the, you calculate the delta bicarbonate. So what should happen to the bicarbonate? The bicarbonate should go up in respiratory acidosis, because the patient's bicarbonate, the PCO has gone up. So automatically your kidney tries to retain some bicarbonate, and then your PCO2 goes up. Your kidney tries to retain bicarbonate and tries to bring up the pH to normalcy. So that's why your change in bicarbonate will be, delta bicarbonate will be 1 by 10 into delta PCO2. So for every 10 change in PCO2 from 40, your bicarbonate will go up by 1. For for chronic, that is more than 24 hours, your delta bicarbonate will be 4 divided by 10 into delta PCO2. So 1 and 4, just remember, in respiratory acidosis, the compensation will be either 1 for acute. So for every 10, it will be 1. For in chronic, it will be for every 10, it will be 4. So that is about respiratory acidosis. Now going on to respiratory alkalosis, like I told, in acute, it is 1 to 2 hours. More than 2 hours is chronic. For acute respiratory alkalosis, the change will be 2 change for every 10 delta PCO2. That means for every 10 for every 10 fall of PCO2, your bicarbonate will drop by 2. Similarly, in chronic, it will be for every 10 drop in PCO2, 10 millimeters of drop in PCO2, your bicarbonate will drop by 5. So what we actually do is we apply these formulas one by one in sequence, and then see whether our pH and then the bicarbonate fits into this one, and that is how we come to know whether this is acute problem or chronic problem, whether it's acute respiratory acidosis or chronic respiratory acidosis, or if it's whether it's acute respiratory alkalosis or chronic respiratory alkalosis. Now let's go to the metabolic disorders. Now in metabolic disorders, your pH comes down, your bicarbonate also comes down, and PCO2 also comes down. And in metabolic acidosis, there are 2 types of metabolic disorders. We actually classify them into. One is a high anion gap, and then the non-anion gap. Now, what are these unmeasured anions? The unmeasured anions are, we all know anions are your sodium, potassium, then your calcium, and then your magnesium. All these things come as your measured anions. Similarly, your unmeasured, the cations are your chloride and then the bicarbonate. Now, what actually the anions and cations are equal in our blood, but we are not able to measure the other anions that are not measured. These are the plasma proteins, your sulfates, your urea, and lactate, etc. These anions should be normally about in the range of about 8 to 12. So if you take uh, so for normal calculation, what we do is we take sodium as an anion, and then you subtract, you add chloride and bicarbonate, and then you subtract sodium minus chloride to bicarbonate. Normally it should be 10 plus or minus 2. So 8 to 12 should be a normal anion gap. If the anion gap is more, then it is high anion gap acidosis. If anion gap is normal, it is non-anion gap acidosis. Now, so in step 5, what we try to do is, I have not talked about metabolic alkalosis because it is little more complex. Alkalosis is little more complex as far as, but it is not a killer. Usually, it doesn't really kill a patient. If patient has got metabolic alkalosis, it doesn't kill, and many times it might not be self-limiting, but at least you will have time to treat it. So I'm not going into much depth about the metabolic alkalosis, but let us see what you look for in step 5. That is, whenever you have a metabolic problem, what is the respiratory compensation for it? So for metabolic acidosis, your expected PCO2, here it is not delta PCO2, it's expected PCO2. It goes by what is called as Winter's equation. It is 1.5 into bicarbonate plus 8 plus or minus 2. So this, if you apply this formula, the patient's the PCO2 should correlate with this one. If it is not so, then the patient might have some other disorder also, along with respiratory disorder, along with the metabolic problem. So that is how we know that we come to know whether it's only a metabolic problem or there's some associated respiratory problem also with the patient. Similarly, for metabolic alkalosis, the expected PCO2, here again the expected PCO2 is 0.7 into bicarbonate. Here it is your derived, the calculated bicarbonate is not the delta bicarbonate, so whatever the bicarbonate, the report is there, plus 21 plus or minus 1.5. So if your actual PCO2, that is what is measured by the machine and then given it to the report, is more than expected, then you know that you have some hidden respiratory acidosis. Similarly, if the patient's actual PCO2 is less than expected, you have some hidden respiratory alkalosis. So that is your step 5. So step 1 is for you look at the pH, say whether it is acidemia or normal or alkalemia. Then step 2 is you determine whether it is a respiratory problem or it's a metabolic problem. Step 3 and step 4 are for respiratory problems. So respiratory, whether it is acute or chronic, and then what is the compensation? That is step 3 and step 4. Step 5, you apply it for metabolic problems. Now, uh, even if there's, like I told, even if there's a metabolic acidosis, is there, so whenever the step 6 is, if there is metabolic acidosis, you should see whether it's a high anion gap acidosis or non-anion gap acidosis. So what are the usual common causes for high anion gap acidosis? It goes by the mnemonic called as mud piles. So methanol, uremia, diabetic ketoacidosis, paraldehyde, infection, ethylene glycol, and salicylate. uh, the infection is nothing but lactate. So lactate can go up in not only in sepsis, it can go up even in any patient who has got anaerobic metabolism. The lactate tends to go up. So if your anion gap is more than 12, it is high anion gap acidosis. There are situations where patients can lose both. So should I? So the other question, what we usually tend to, what we should remember is, should I calculate anion gap even when there's no acidemia? Means with the patient, when you look at the patient has got a respiratory problem, should I still calculate? Yes, because patients can have respiratory primary problem. Along with it, they can have some hidden metabolic acidosis also with them. So always calculate anion gap even if it's a respiratory, if it's a primary respiratory problem. So next step is what is called as a delta anion gap. If you are not able to understand this, it's fine. But what it infers is, see, there can be patients who have got metabolic acidosis along with alkalosis also sometimes. Similarly, patients can have high anion gap acidosis as well as non-anion gap acidosis. So generally what should happen is your delta anion, that is your change in anion gap. That is anion gap, I told you, it's about 12. Now, the change in anion gap is the patient's anion gap minus 12. This change should be normally equal to the change in bicarbonate. The change in bicarbonate is 24. So if the patient's bicarbonate is 12, that means the change is 24 minus 12 is 12. So if the patient's anion gap is also 12, then I know this patient has got purely, the patient has got high anion gap acidosis. And patients, it is only purely if the delta anion gap is greater than this one, then it might be patient might have some additional metabolic alkalosis. Similarly, if your delta anion gap is less, you consider non-gap metabolic acidosis. This is little complex to understand, but even if you don't remember, it's fine. But just remember, there's something called as gap. This is what is called as gap. Gap is nothing but patients can have both non-anion gap acidosis as well as high anion gap acidosis. Sometimes they can have high anion gap acidosis along with metabolic alkalosis also. So what are the causes for non-anion gap acidosis? So patients can actually lose both, but some of the patients can lose both anions and cations. Like for patients who have GI loss, they've got loose stools or vomiting, they tend to develop, not vomiting, you actually lose chloride also. That's why they get alkalotic. Whereas if they got diarrhea, generally they'll have acidosis. But if you look at the anion gap, there'll be normal anion gap. Similarly, patients who got renal tubular acidosis, let it be type 2, type 1, type, all this one, they all have non-anion gap acidosis. Then patients who receive non-high chloride containing solution for long periods, like patients, if you infuse sodium chloride uh, 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 for means more than a liter or something, patients do develop high chloride, chloride, hyperchloremia, and that can itself lead to acidosis. But if you calculate the anion gap, it will be normal for these patients. So as far as metabolic alkalosis is concerned, we always look at whether it's chloride responsive or non-chloride responsive. I'll not go into it. Just remember that chloride responsive patients, they respond to chloride. You give chloride containing solutions, they respond. So in metabolic alkalosis, most of the time the volume contracted, and so they tend to, you give most of the time we end up we start treating them with chloride containing solution, sodium chloride, uh, or the patients can have chloride loss. like whenever they got a tubular dysfunction, they can have chloride loss. Non-chloride responsive are patients who got mineralocorticoid excess, which we don't come across so often in ICUs. Now, step 8 is, like I told you, calculating a AA difference. AA difference, with the AA difference, I already spoke about this in the initial part. So you calculate the ideal, using the ideal alveolar equation, you calculate your partial pressure of alveolar oxygen. Then you have your partial pressure of oxygen that is measured by the machine. You take the difference, and the difference is more than 10. It tells you that patient has got oxygenation failure. If the A difference is normal, patient got ventilation failure. Most of the time, patients who got ventilation failure will also have some amount of oxygenation failure as well. Whereas the other one, the hypoxemic patient, the patients who got shunts, means patient who got pneumonia. Because of this, what is happening? There are parts of lung that is not getting ventilated but getting perfused. So it's a pathological shunt. There you have a AA difference that is large, so it is more than 10. Whereas if a patient got purely respiratory acidosis because of CO2 retention, this patient, if you calculate the the AA difference, it will be normal. One thing what you should remember is post anesthesia, post general anesthesia, we do come across hypoxemia. The reason for this hypoxemia is because of hyperventilation, where the patients actually retain carbon dioxide. You give oxygen, your oxygen might come up, your saturation will improve. But what happens during general anesthesia is they all recover. Means after some time, the patient starts ventilating, the ventilation becomes normal, and because of this, is CO2, he washes out his CO2, and he doesn't need oxygen, no longer needs oxygen. Whereas the same thing, if I apply to a CO2, the patient who got COPD coming with high PCO2 is hypoxemic, I start oxygen, momentarily the saturation will go up. You will see that the SpO2 is picking up, and you might think that patient, we have done good to the patient. But on the contrary, if you don't take care of that PCO2, after some time is going to become more and more, is going to become more hypercarbic. At some point, you might even become unconscious, and then subsequently you might realize that he's hyperventilating, and is needing. You might go on to a ventilator also. So that is something what is remember. Post anesthesia also the same. The only thing is post anesthesia, they all tend to wake up, so the ventilation becomes normal, and that's how they actually the requirement might come down. Apart from this, they do have some amount of shunt also, because they can have atelectasis. They can have some amount of in case patient has got some mucus plug inside, some of part of the lung might not be getting ventilated. But most of the time, patients with normal lungs, they hyperventilate, that's why they become hypoxemic. So generally, if you as the anesthetic effect goes off, you tend to normalize. So that is something what you should remember. And in day-to-day practice, what do we do for as far as whenever you look at your PaO2 in your ABG, that is a P arterial O2. Look at the ABG, you always calculate your PaO2 FiO2 ratio, and this goes by the name as Horowitz ratio or your Karekko ratio. Normally, it's about 400 to 500 millimeters of mercury. And in ARDS, whenever we call it as ARDS, whenever it comes below 300, and less than 100 is severe ARDS. So this is one index we usually whenever we talk about oxygenation of the patient, we always talk about the PF ratio. Now, I think we can have some introduction here. So I'll go to few ABGs.
మళ్ళీ ఇంకోటి ఏదో మెచ్యూర్ అయింది కదా ఒకటి నవంబర్.
A 30-year-old female with sudden onset of dyspnea, no cough or chest pain, vitals are normal, but respiratory rate is 26 per minute. She's anxious. So this is a very young lady without any comorbidities. She has no cough, no chest pain, and it's sudden onset dyspnea, and vitals are normal. She's very anxious, and then the respiratory rate is 26. Now, what do we do now? Now, always look at the history first. That is the first thing. So it's a probably patient has got no comorbidities. She's anxious for some reason, and then she started hyperventilating. So when you look at the first step is always look at the pH. So what is the pH here? pH is, so if some participant can answer, it'd be good for me. Otherwise also I'll do it. Okay, so the pH is 7.48. So what is it? It is respiratory alkalosis. Sorry, it is alkalosis. So what is the next step I do? I look at the PCO2. PCO2 is 30 here. So it becomes respiratory alkalosis. So now I look at the I took just to make sure I'm right. So pH has gone up, PCO has come down, and then I look at the bicarbonate is 23 point. That is almost normal. 24 plus or minus 4 is what is normal. So it is a respiratory problem. So respiratory alkalosis. Now what is the next step I do? I check whether it is acute respiratory alkalosis or chronic respiratory alkalosis. So what is the expected pH? I calculate the delta pH. Delta pH for acute is 0.08 into 10 divided by 10. So 10 because 40 minus 30 is 10. So that is why it is 0.08 here. So expected pH is 7.48. What is the patient's pH here? Patient's pH is again 7.48. So it is acute respiratory alkalosis. Now let me put the other formula also. So that is how we do. Suppose this doesn't fit in, you put the other formula. The chronic delta pH is 7.03 into 10 to the 10 by 10. That is 0.03. So expected pH is 7.43. Patient's pH is 7.48 now. So it is acute respiratory alkalosis. So once it is a respiratory problem, I should go to the next step. What is the next step? I look for compensation. What is the compensation here? I look at the bicarbonate. The bicarbonate in acute, it should have its alkalosis, so it should have it should have dropped by 2. So for every change in your delta bicarbonate should, for every 10 change, it should have dropped by 2. So 2 into 10 by 10, that's your 2. So bicarbonate should have been 22, whereas here it is 23.9. So it is very acute, it is less than 1 hour. So most probably it is either not, she's not yet started compensating, or she might have some, very rarely you might have a mixed disorder also. At least this much you can infer from this ABG. So for that, what do? I always calculate the anion gap. Anion gap in this patient is 11. So that is normal. Now look at the oxygenation. The patient is breathing at room air, and your PO2 is 105. So 105 is normal. So I don't think I have to go any further by calculating your AA difference and or AA difference. So next patient, let us go to the second patient. This is a 60-year-old male smoker with progressive respiratory distress and somnolence. So from the history, this guy is a smoker, and then he's got progressive respiratory distress. That means it's happened over a period of time. And now let us look at this. What is the first step we do? We look at the pH. Now what is the pH here? pH is 7.30. So it is less than 7.35. So it becomes respiratory. Sorry, it is acidemia. Now look at, so what is the next step I do? I look at the, so acidemia. So next step is I have to ascertain whether it is metabolic or respiratory. Let me look at the PCO2. PCOP, partial pressure of carbon dioxide is 76. That is measured by the machine. So I know it is more than 40. That means it is respiratory acidemia. Now, once I do that, next is I have to check whether it is acute respiratory acidosis, acidemia, or chronic respiratory acidemia. So what do? I take, I apply your delta pH formula for acute and chronic. So I'll do that now. Now, the delta PCO2 for this patient is 76 minus 40. So like I told, your PCO2 is taken as 40 as normal. Similarly, bicarbonate is taken as 24 as normal. Now, and pH is 7.40. Now, what is the change in PCO2 here? 76 minus 40 is 36. So there's a rise of 36. So what will be the delta pH? If for acute, it will be 36 by 10 into 0.08. So for every 10, that for every, so 3.6 into 0.0, that's 7.29. So if it's acute this one, your pH should have been 7.11. So what is the patient's pH here? It is not 7.1, it is 7.30. So I'll apply the second formula, that is your chronic this one. So pH, again here it is 0.03 into 36 by 10. So that will be 0.1. So let me apply this one. 7.40 minus 0.10 is 7.30. So that fits here. So it is chronic respiratory acidosis. This much I know. Now next is I have to look at the compensation. What should be normal compensation? Your PCO2 is gone up, so bicarbonate should also go up. Now it's chronic. So for every 10 change in PCO2, the bicarbonate should have gone by 4. That's 2. Just remember 1 and 4 and 2 and 5. For respiratory alcohols, it's 2 and 5. Respiratory acidosis is 1 and 4. So it should have gone up by 4. So what has happened? Delta bicarbonate is 4 divided by 10 of delta PCO2. That is 4 by 10 into 36. So that will be 14.4. Now limits of bicarbonate is, it can be as high as 38. So here it is 36.1. So this is where you should also look at your anion gap. Now this is not fitting here, isn't it? The bicarbonate is less than what you have calculated. So there might be patients who have got uh, respiratory acidosis along with metabolic acidosis also. So you look at the anion gap, you might get an idea. I have not done it in this patient, but this is something what you should remember. Whenever it's not correlating, just check your anion gap. And if the patient has got some high anion gap, maybe this patient has got some hidden metabolic acidosis. Also. Maybe the patient has got some lactate also, that is lactic acidosis also along with it. And then look at the hypoxemia. What is the AA gradient here? The machine itself has given you the AA gradient is 9.5. That is less than 10. So that is normal AA gradient. And you know it is because of hyperventilation and not because of patient is hypoxemic because of the rise in PCO2, not because there's no lack of oxygen for him. It is because of ventilation problem is become hypoxemic. Now case 3, this is a lady who is male, 18-year-old asthmatic, 3 days of cough, dyspnea and orthopnea, not responding to usual bronchodilators. Now on examination, he is in distress. He's got suprasternal and intercostal retraction and is looking tired and is on 4 liters of nasal cannula. Now let's go one by one. Now first step is always look at the pH. pH here is 7.23. 7.23 is acidosis. So once I know it is acidemia, I have to check whether it is respiratory or metabolic. Look at the PCO2. PCO2 is 60.1. That is normal. It's 40. It is more than 40. So obviously you have it is respiratory acidemia, respiratory acidosis. Now I have to I have to check whether this patient has got acute respiratory acidosis or is it chronic respiratory acidosis. So what do I do next? I apply the delta pH formula. So that is your, so first I'll calculate the delta PCO2. Delta PCO2 60 minus 40, that is 20. Then I calculate the expected acute, if it is acute, the delta pH should have been 20 by 10. So that is 20 is the change in PCO2 by 10 into 0.08. So that will be 0.16. So acute, the pH should have been 7.40 minus 0.16, that's 7.24. The patient's pH is here 7.23. So it is not correlating. So there are situations where patients can have associated metabolic acidosis also. That is something what you should remember. So this patient might have respiratory. So I'll just remember that, okay, I have to look at the metabolic problem also in this patient. Now let's go to the next step now. Now the next step is your compensation. What is the compensation here? Your bicarbonate should actually go up. So what is the patient's bicarbonate here? What is given by the machine is 24.5. So your delta bicarbonate should have been 1 by 10 of delta PCO2. The delta PCO2 1 is because it's acute respiratory acidosis. So 1 divided by 10 into 20 is 2. So limits should have been 26. So that's 26, whereas your patient's bicarbonate is only 24. So is there a metabolic acidosis in this? So this is where I use my anion gap. I have not given in this report, but I calculated, I got the values and then I calculated. I get a value of 16. 16 is more than 12. So it is high anion gap. So this patient has got some he's got acute respiratory acidosis along with high anion gap acidosis. So that is what we try to do. Next is look at the oxygenation. Patient's PO2 is 66. So less than 80 is hypoxia, but it is okay. But you should, and once patient has got hypoxemia, look at the AA difference. How do you calculate the AA difference? You first calculate your PiO2, so alveolar O2. Then so alveolar O2 is 129. 129 minus your PO2, that's your PaO2 is So it is 63. So it's high A difference. So that means patient has got oxygenation failure here. This is the last case, case 4. This patient is a 28-year-old diabetic with respiratory distress, fatigue, and loss of appetite. So, diabetic coming into respiratory distress, fatigue, and loss of appetite. Now, let's go one by one. Now, the first step is always look at the pH 7.23. It is acidemia. So next is I have to see whether this acidemia is because of respiratory or metabolic. I look at the PCO2. PCO2 here is 34. It is not fitting into respiratory acidemia for sure. Patient, on the contrary, the PCO2 is slightly low. So now let's go look at the bicarbonate. The bicarbonate is 14 millimoles per liter. So that tells me that this is metabolic acidosis. This is for sure. Now, what do I do if it is a metabolic problem? I use my, so acidemia, so metabolic acidemia. So the expected PCO2 is what we calculate here. The expected PCO2 should be 1.5 into bicarbonate plus 8 plus or minus 2. So that will be 1.5 into 14. So it will be somewhere between 27 to 31. So what is the patient's, this one here, PCO2? It is not either 27 or it is not 31 or it's not anywhere near. So there is some, there's a patient has got some amount of respiratory acidosis also. So this is how sometimes this is how we need to see whether there can be patients who got mixed disorders also. If it is not fixing into this, patients can have mixed disorder. Now, what do we do next? If at all, if I know it's metabolic acidosis, I have to say whether it's high anion gap or normal anion gap. So 130 is your sodium, chloride is 100, and then your bicarbonate we take it from here 14. So that is 16. 16 is 12, more than 12. So it is high anion gap acidosis. So now once I know it is high anion gap acidosis, so normal anion gap is 12. So this patient's gap is 16. So 16 minus 12 is 4. So this is your delta gap. Now look at the patient's bicarbonate is 14. So the 24 minus 14 is 10. Now this anion gap should have been, the delta gap should have correlated with this gap. If it is not so, then patient has got some additional non-gap acidosis as well. So in fact, this patient has got a metabolic acidosis, which has got both high anion gap and normal anion gap, plus this patient has got a respiratory acidosis also. So if you can go to this precision, and with anion gap, if you know the albumin also, they say it is almost equal to, if you use a Boston's rule, you can actually, if you get your albumin also along with this one, you can actually be as sure as your Stewart's approach. But in day-to-day practice, we don't have to actually get into so much of details. At least know that, okay, this patient has got high anion gap acidosis, and probably what is the reason? It might be lactate high, that is high, or it might be the diabetic ketoacidosis, or it might be uremia. So if at all we know at least this much, that's enough for us. Similarly, if the patient got respiratory acidosis, whether this bicarbonate is compensated or not, if it's not compensated, then what is the problem? Is it because the kidney is not able to retain bicarbonate, or if the patient has got other associated other metabolic problems? So this much, if you're able to analyze, that's enough. So I think there are few more ABGs. I think I'll stop here. I'll be happy to take questions, and it is complex. But what I suggest is I can share the slides, and you have a copy of it with you, and start working with the ABGs. Nothing like we working on this one. And whatever I learned, it is over a period of time. It is not 1 day or 2 days. From the time I joined WIMS Bellary, the physiology that I learned from Dr. K.J. Mariswamy, subsequently Guldat sir, Bhaskar sir, and others, Dr. Devan, and so many teachers, it all has actually helped me take it forward. And even now, I'm not a master in the blood gases, but at least I can manage to an extent and take care of patients. So that confidence it actually gave me, because of all this training, and then the training and retraining that happened over a period of years. Thank you, sir. If any questions, I'll be able to answer, and any clarifications I can. It involves some formulas, but over a period of time, if you get accustomed to it, then it's nothing like that. You can just keep working one by one by one by one. can just go on.
Kiran?
Yes, sir.
Yeah,
Yes.
I think that was an excellent and exhaustive presentation, Satya. I think the session is open for questions from anybody or comments from the seniors, our teachers.
In fact, the first time I attended Dr. Panilnath Tota's lecture in Bangalore, it's on he used to use base X base deficit and then the nomogram. That notes is still with me. It is phenomenal. I'll tell you. I think we all it's an inspiration to read those notes, and of course learning from Dr. Gurudat, learning from other doctors.
Dr. Satyamurthy.
Yes, sir. Yes, sir.
Yeah, we have covered both theoretical and clinical aspects of it comprehensively. Congratulations. One question that may be beneficial to everybody. Metabolic acidosis.
You are not
Your
audible.
audio is, you're not audible.
Okay.
Network.
What is the pH at which I can go on giving?
Sir, you are not
audible?
clear, sir.
You are not.
Okay.
Audible, sir. Yes. So you are asking about use of bicarbonate, sir?
Bicarbonate for both metabolic acidosis, and is there any role in severe respiratory acidosis?
Giving bicarbonate, sir?
Yeah, yes.
Sir, we do use it, sir. When they have refractory hypoxemia, we prone them and then we ventilate them with very low tidal volumes. What happens is we end up patients developing respiratory acidosis, sir. And the pH drops to even less than 7.20. In that case, we use the bicarbonate as an infusion. Either we mix it in what I have learned is I usually mix even for other metabolic acidosis also. Giving the bicarbonate is not that harmful as we all thought, sir. In fact, I think one study recently has come where they have actually infused bicarbonate for patients who got metabolic acidosis for other reasons also. What I usually do is I take half normal saline, 450 ml. I add 50 ml of bicarbonate, and this itself I run as a infusion. So by the why I use half NS is the sodium content. If you're using saline and then adding bicarbonate to it, the sodium content goes up phenomenally. So instead of that, you use half NS or even 5% extra. If the patient is not hyperglycemic, your bicarbonate also goes up, and then your sodium also doesn't go up. So even in respiratory acidosis, especially in ARDS, when you prone them, we do use infusions, bicarbonate infusion. We try to keep the pH more than 7.20 as much as possible.
Excellent lecture, Satyamurthy. Very happy.
Thank you,
you simplified the whole process. So one thing I just want to add about the authenticity of your ABG. So
yes, sir.
You can even calculate first of all the authenticity of your ABG, whether the machine is giving properly or not.
Yes, sir. Yes, sir.
Yeah.
Yes.
So can you just explain about the authenticity, how to calculate? Usually you calculate the hydrogen ions, isn't it? So
yes,
80 minus the last two digits of the ABG should be the hydrogen ion. And can you just explain so that everybody will come to know about this authenticity of your...
I didn't... Authenticity of the...
ABG,
sir,
first of all.
Okay, sir.
ABG, whatever the ABG we are getting is properly done by the machine or not? Can we, rely on all the, whatever the results that we have got?
Okay, sir. So I'm sorry, sir. I don't know. You can just tell us.
No, for example, now you are showing this 7.267 as the pH here on this slide.
Yes, sir. Yes, sir.
So this 0.26 is the last two digits. So 80 minus this 26, this is the last two digits you take. That should be the hydrogen ion of this particular patient's blood.
Okay.
Okay, now
concentration.
we go with the formula hydrogen is equal to the PCO2 into 24 divided by bicarb.
Okay. Yeah. Okay, sir. Okay, sir.
Yeah,
Yes,
suppose
I got it. Yes,
if
sir.
this is
Not
the
correlated.
PCO2 is 40 into 24 and divided by 24 is normal bicarb. So you will have a hydrogen ion concentration of 40. Now in this patient, you calculate the hydrogen ions using this formula. Hydrogen ion is equal to 24 into PCO2 divided by the bicarb. So 80 minus this last two digits should be the hydrogen ions.
Okay.
So if both are correlating, then you know that this whatever the values that are there are authentic. So this is one thing I think to start with we can always go with. We'll know
Yes,
that whether
surely, sir.
the machine is giving us the correct values or not.
Correct value or not.
Yeah.
Thank you, sir.
Otherwise everything was
the
fine.
In fact,
basic
I
one.
didn't know this, sir. Thank you very much. I'll
Okay.
definitely
Yeah, you can
practice
definitely
on.
use this to
Yes,
start
sir.
with.
Yes, sir.
Yeah.
Yeah, I see Amulya raising hand. Any questions?
Yes.
Yes, Amulya, go ahead.
Just saying hi, or it's a question, Dr. Amulya. Okay, just have another technical question. The initial,
Yes, sir.
we heard technical aspects discussed in
Yes,
the
sir.
initial part, like how we should draw, how much should be the amount of heparin, and you
Sir,
also talked
yes,
about
sir.
how we should be, added to a crushed ice in a container.
Yes, yeah, I
What about like straight away collecting, and if there
have
are
a personal
air bubbles within the syringe?
you
Sir, ideally we should take off the air bubbles, sir, because air
use
bubbles, if it is there, it is going to take off
Yeah.
to an extent the carbon dioxide in it. The carbon dioxide tend to drop whenever the air bubbles are there. So the moment you take the sample, you have to de-air the sample, sir. That is one. Number two is, like I told, the 2 ml is what is all the time told. So we have to draw at least 2 ml. And when you take heparin, you have to rinse the heparin and then completely flush it out so that there's no heparin in it. Sir.
Is it too significant? In the sense, what I'm trying to tell is, if there is a
Yes,
2
sir.
ml you have drawn, so if you think there are, for example, 3 to 4 drops of air in between, it's going to significantly affect the PCO2 values and therefore the pH values.
It won't be that high, sir. It won't drop so much.
Okay.
Out with us walking.
Yeah. Somebody wants to have a question. So I have Dr. Kannu. In which situation VBG will suffice? That's a question.
Okay, sir. Sir, as far as acid-base status is concerned, venous and arterial are almost they correlate, sir. But oxygenation, definitely we need to have blood gas. Otherwise, especially my pediatric friends, they just go with venous blood gas most of the time. They just go by to look at the electrolytes, immediately they get the value. So that is one advantage of venous blood gas.
So it won't affect the management much.
Not much, sir.
So Balaji has got some question. Balaji raised the hand. Okay, anybody else? So it's like ABG
have you used it?
moment for the duration you hear, everything is comfortable for the students. So nice thing that you put an example.
No, it's more of we need to keep reading, so that's the only thing.
You should be in touch with any ABG report. We should just
I feel at least 1 more month ke baad he can think of that, no? ಏನಾದ್ರೂ ಆದ್ರೆ they are not strong enough to
Somebody's,
hold uncle in case he.
I'll mute everybody once then.
So, as you said, Dr. Satya, so
Yes, sir.
it is, repeatedly the students,
Yes,
when
sir.
they go to the ICOs, they should open up the ABG reports and then keep, reading it. So then
Yes.
only repeated reading, and especially using all those equations, Winter's equations, whatever you had told.
Yes.
So
Yes,
those
sir.
are very, very important. Otherwise, it will be very confusing otherwise. Suddenly, if you start using for the first time. So keep reading the ABGs. So then definitely, it won't take much time to interpret an ABG. And always clinically correlate the ABG. It is not
Yes,
just the ABG like, the ECG or what X-ray chest or whatever it may be. Everything should be correlated clinically, and then only you have to take a decision to treat or not to treat. So that is very, very important.
Just like an ECG, we normally insist on people to read the ECG.
Correct.
Stepwise. So trying to jump to a final diagnosis will never take you further.
Yes. Yes.
That's the most important thing. And second thing is, for understanding ABG, some background respiratory physiology is very important.
Sure.
Now, if somebody is not good in respiratory physiology,
That
I
is
don't
why.
think. Yes,
No, I want one of you to talk about Stewart's approach sometimes, sir. Either Bhaskar sir or Gurudat sir, because even now I find it very difficult to understand.
Strong ion
Stewart's.
difference. It
Yes,
goes
sir.
with a strong ion difference.
Yes, sir. Yes.
Method.
Because
SID.
I keep reading, but still I get stuck. So one of you can take a class on this one, sir.
Sir could do, or we will have a good, our own intensivist. I mean, people who are
some intensivist is always better
in our group. So definitely we will have them in one of our next few meetings.
Sure, sir. Sure.
Just to convey here, this session we had run live on YouTube also, apart from this forum. So first time we have run it on YouTube also. And second thing is, at the end of this academic session, we will close the session. We'll come back in a moment. I already put a link for next meeting. You can just log out and then rejoin with that new ID. So this is for our social discussions among the group.
Okay.
So any other questions from the postgraduates and the participants? I have Dr. Kamesha Rao who is participating today. I'm very happy. Welcome, sir, on behalf of ISA Ballari and the group.
Good evening, sir.
You can unmute, sir.
Thank you very much, sir. Very nice to see you and Dr. Gurudas, sir.
Good evening, sir.
And good